Good evening, everyone. A very warm welcome to today's ISU USI's Digest Smart Learning Program. And today's topic is Renovascular Hypertension, the topic which we have seldom discussed in our previous ISU programs. And this is based on the feedback which you have written to us to cover this topic. And we are lucky that this topic is being covered by a very experienced and esteemed faculty, a man of a wealth of knowledge as well as the skills, Professor Ganesh Balakrishnan. He has structured the whole of this class into different portions, and I think that will cover the whole subject. So I urge you to stay active during the whole program, and please post your doubts and queries in the chat box. Now I just invite the President Urology Society of India, Dr. Sanjay Kulkarni, to give his introductory and welcome remarks, followed by Honorary Secretary USA, Dr. Lakshmi Prabhu, to give his comments. Over to you, sir.
Thank you, Dr. Arun Chawla. So it's a great privilege for me to introduce Dr. Ganesh Gopalakrishnan, and he is one of the most respected teachers in India, and past president of Urology Society of India, was professor of urology, head of the department at the most famous department of urology at CMC Vellore, and then he shifted post-retirement to Vedanayagam Hospital, where he continues to teach and operate on very difficult cases. I know that he came to Pune a couple of times to operate on very complex cases, and we are fortunate that Ganesh is with us to give us a talk on renovascular hypertension, which is a very difficult topic, and not many urologists deal with this kind of surgery. So Ganesh, welcome.
Yeah, good evening, everyone. Thank you, Ganesh sir, for accepting to do this class. And when it is Dr. Ganesh Gopalakrishnan, it is time to learn and not to make any comments. Thank you very much. I'm sure we will have a great time learning from him. Thank you very much.
Yes, thank you, sir. And with these few words, I would like to introduce Dr. Ganesh Gopalakrishnan as an exemplary teacher and a gifted surgeon, and a stamina to put all us urologists to wonder how can he do these surgeries for ours, and where does this zeal come from. He's been a teacher and mentor to many of urologists from Tamil Nadu and all over India. And all you need is a phone call to him whenever you are in a difficult surgical problem. Apart from being a BC Royal awardee, he is a fellow of Royal College of Surgeons and an extraordinarily down-to-earth person. I've assisted him for a lot of complex reconstructive surgeries, and the only thing I am afraid of that he uses one suture at a time, and you have to keep a lot of sutures in the OT. With this few remarks, I would like to hand over the mic to Dr. Ganesh.
Thank you very much to USI, to the president, the secretary, the chairman of ISU, and the vice chairman of ISU. It's indeed a privilege to be here this evening and participate in as part of the teaching program of the Indian School of Urology. Today, there has been a plethora of lectures, talks these days, various fora, and I think the urologists and the residents all put together are being bombarded on all sides by so much of information and material. I think they're finding it difficult to choose where to go to. And let me get down to the business of this particular talk today, and that is on renovascular hypertension. Let me also echo what Arun said a couple of minutes ago, that this is a topic that many people are not familiar with, simply because they don't deal with this in their day-to-day practice. As I see this particular condition over the last so many years, being in Vellore and then now here, that urologists who are only involved in large multi-specialty institutions or large teaching institutions where you have these patients coming in to various other departments, the common urologist is not going to see them. He probably will not even handle them. And this may be just for the purpose of somebody writing an exam or passing the exam or something of that nature. So, for many people, this would just be way over unnecessary. But nevertheless, as urologists and as people involved in renal transplantation, we just need to know what the score is as far as renovascular hypertension is concerned. My slide's not moving. For some reason, the slide's not moving. Hang on, I'm trying to move my slides. Can I
So you
just go
can
back?
go to arrow on the bottom of the laptop. There's one keyboard which showing
Okay,
the
right, I got
arrow.
it. I got it. Thank you. I got it. Thank you. Well, how would you define renal hypertension? Renal hypertension is actually a form of systemic hypertension, consequent to occlusive disease of the renal artery. That is where it comes as renovascular hypertension. And it is assumed, again repeat, it is assumed that if you correct these lesions of the renal artery, then the hypertension will be cured. And therefore, many years ago, when this disease was thought about, discovered, it was felt that this is one of the curable causes of hypertension. And over the years, we have realized that it certainly is not one of those curable causes of hypertension. And at best, in many situations, we are only able to control the hypertension in the vast majority of the cases. And this is only because of the fact that there have been no singular randomized control studies to state that surgical attack on the renal artery will actually reverse the hypertension completely and make the patient cured of this disease. So I just want to reiterate that statement, that don't get carried away by the fact that just because you're going to do something on the renal artery, that this patient is going to get rid of all his antihypertensive drugs. Simply because renal hypertension is a form of systemic hypertension. And therefore, the target organs, the end arterioles, the arterioles, and the peripheral resistance factors all come into play in trying to keep this hypertension going. But at best, if it is directly mediated by renin, then we have a reasonable chance that it can be controlled or cured. As far as JNC7 is concerned, hypertension was defined as a blood pressure which is less than 130/80 millimeters of mercury. And it seems that every year somebody is going on tweaking these values. And we must remember that as you are older in age, then some of these criteria for hypertension need to be taken with significant pinches of salt, because if you lower the blood pressure too much in some of the elderly people, they could have other systemic side effects. We therefore have, in this category of hypertension, you have renovascular disease. That means a disease process affecting the renal artery. You have renovascular hypertension, which is as a consequence of renovascular disease, and particularly renovascular disease. If you have renal artery stenosis per se, then you could say that yes, this is some form of renal hypertension. So you have renovascular disease, renovascular hypertension, and renal artery stenosis. And this is where the issue comes in. Is it curable hypertension or is it controllable hypertension? As far as epidemiology is concerned, renovascular hypertension occurs in about 1 to 3% of hypertensives. So it's a very rare cause of hypertension. If you look at somebody beyond the age of 65 years, 8% of them will have 60% occlusion of the renal artery. These are big values, big values. Over the age of 65, 8% of the population is likely to have 60% occlusion of the renal artery. If you have coronary artery disease, 18 to 25% of people will have concurrent renal artery disease with 50% occlusion of the renal artery. Therefore, many cardiologists, when they do the angiogram for the heart, they actually do an aortic runoff to know whether there is renal artery disease. But we must be extremely careful not to meddle with things which nature has been controlling. So just because you got a renal artery narrowing, it doesn't mean you go and put a balloon as part of your treatment protocol and treat the hypertension. If you have peripheral vascular disease, then 35 to 50% of people are likely to have renal artery disease. And I'm sure that many people, when they screen their donors, we ourselves have had this problem, that about 6% of normotensive potential kidney donors could have fibromuscular disease. So as far as this condition is concerned, it is myriad. It has got numerous ramifications, and we must be extremely, extremely careful not to treat an X-ray picture just because you happen to have it there, but actually to treat the patient's symptoms and go by certain guidelines and yardsticks. If you look at pathology, there are basically, in the books, they will only talk about two main pathologies affecting the renal artery. One is atherosclerosis, the other is fibromuscular dysplasia. But in our country, aortoarthritis is a significant cause of renal artery disease. And we see it in this country, we see it in the Far East, and sadly in the West, they don't seem to have heard of this disease. And therefore, it is not even in the textbooks of urology as aortoarthritis. As far as pathology and atherosclerosis is concerned, we know that older people, the male factor, smoking, diabetes, dyslipidemia, etc., are responsible for the occurrence of atherosclerosis. However, if you look at the disease process itself, it is invariably an osteostenosis or involving the proximal renal artery. It is invariably bilateral and invariably progressive. It is important to know how the natural history of certain pathological conditions unfold so that you can offer appropriate treatment to these patients. If you look at fibromuscular disease, FMD, or fibromuscular dysplasia, it's usually in young women between the ages of 15 to 50 years. And we have three varieties. Just like we have three linings within the three layers within any artery, we have intima, media, and the periadventitia. The intimal variety of fibromuscular dysplasia or fibromuscular disease usually affects children and young adults. It is a very intense stenosis. It causes complete stenosis of the renal artery, and it is not usually amenable to any form of endovascular interventions. It's a very, very tight stenosis and progressive, and therefore many children and young adults lose their kidneys as a consequence of this particular process. The medial fibroplasia, or the classical string of beads, is an incidental finding. We see this in our kidney donors particularly. They are young women, usually affecting the right side, and it is claimed that because the right side has got more ptosis, that this renal artery undergoes these sort of changes of string of beads. It is usually stable unless patient has other risk factors, and therefore, just because you have this on an X-ray doesn't mean you go and do some surgical correction or some form of endovascular procedures unless you have significant risk factors in that particular individual. The subadventitial or the periadventitial type of fibromuscular disease is again just like the intimal variety, very tight occlusion, progressive, and invariably leads to dissection of the renal artery. And therefore, both intimal and adventitial varieties of fibromuscular disease require to be addressed, require to be treated. What about aortoarthritis? Now, this is a very interesting condition and is popularly known as Takayasu's arthritis because it's described by this Japanese ophthalmologist called Takayasu. He saw it in the fundoscopy, and then later on realized that many people have vascular disease which affects the aorta and invariably all its branches, carotid, subclavian, renal artery, etc. And nobody knows what is caused, but it appears that this may be an inflammatory response secondary to some immunological process. There is no proof that this was TB, although there are a lot of books in our country written by famous cardiac surgeons, famous cardiologists, that this is TB. I personally have looked at this very closely when I was in Vellore. We've sent lymph nodes from these patients. We've actually taken biopsies of these lesions, and we haven't yet been able to prove that this is tuberculosis. Although I know many patients are treated with anti-tuberculous treatment on a hunch that this could be TB. Sometimes you have a very inflammatory type of disease which is still present, and therefore in the process of evaluation you have a raised CRP, a raised ESR, and a raised LDH. And these markers are invariably useful in trying to decide whether you want to do any surgical treatment or continue with medical management in patients with aortoarthritis. When we come to the immunological reasons for this, this is why some people, when they find that these markers are elevated, would actually put these patients on either steroids or one of these immune modulating drugs like even azathioprine or mycophenolate mofetil, and see whether these marker levels actually come down. These are non-specific markers, nothing specific, and see whether they come down. And then, okay, if the disease still continues, then you go ahead and do some form of intervention or treatment for these patients. There are many classifications for Takayasu's arthritis, but this is the simple one, Nasu's classification. You have basically 4 types: the supraortic involvement, the type 2 is the aortic arch and its branches, type 3 is the abdominal aorta, including the renal arteries, and type 4 is a combination of 2 and 3. But some people have also included the pulmonary artery. When that gets involved, then it becomes a type 4. So, there are various classifications and a lot of complex classifications as far as Takayasu is concerned. There have been actually workshops conducted on Takayasu's arthritis, and there are many people who have given their own classification to this condition. The diagnostic criteria of Takayasu's arthritis again is very complex, and just like many conditions, we have obligatory criteria, major criteria, and minor criteria to actually diagnose this condition. But one of the most classical features of this particular form of arthritis is that invariably the left subclavian artery gets involved. Invariably. In most of the cases, you will find that you can't record the blood pressure in the left upper limb. Sometimes the carotids can be involved, and in some situations, the superior mesenteric can be involved. If the superior mesenteric is involved, then nature takes charge, and through the inferior mesenteric artery and through the marginal artery of Reola, you get the entire small gut being filled up with blood. And therefore, when you see an X-ray where there is superior mesenteric artery narrowing, many patients may have no abdominal symptoms, no abdominal angina at all. And that is because of the extreme vascularity which is being supplied through the marginal artery of Drummond, or Raiola as some people call it. It is also very important to recognize that don't fiddle with this artery. Leave that marginal artery alone. Don't touch it. The moment you go fiddling with it, you will destroy the entire small gut. You try to re-anastomose something there, use that artery because it is sitting there for something else, you will end up with gangrene. So leave that marginal artery of Reola alone. So these are some of the criteria that are used for diagnosing Takayasu's arthritis. But in many situations, you have, as I said, the renal artery involved. You have many of these arteries involved, including the arch of the aorta. I think it's important, even if you're not interested in renovascular hypertension, you're not interested in this topic, it's a waste of time. You will certainly be asked about this in the exam. Or there will be a theory question on renal angiotensin-aldosterone cascade. And you must know that diagram. And if you write that diagram, you can be certain that you will get your marks. So this is an important theory question. It comes regularly in both DNB and the MCH exams. And therefore, it is mandatory for you to know that this is the cascade that takes place. the renin being mediated from the JGA in the kidney, and then through the angiotensin-aldosterone arcade involving the receptors in the lung and subsequently in the liver, you get the effect of secondary, you get the effect of hypertension. And as a result of this, you get the aldosterone being secreted and resulting in secondary aldosteronism, and that again adds to the cascade of hypertension. It would be important at this point for me to emphasize the Goldblatt model, the 2 kidney 1 clip and the 1 kidney 1 clip model. And this is because of the fact that when you have a single kidney and there's a renal artery narrowing or renal artery stenosis, then that index kidney produces the hypertension because of renin. But very soon, this hypertension through the renin angiotensin aldosterone cascade, what happens is that it then becomes a salt-dependent hypertension because of the effect of aldosterone. And therefore, in a 1 kidney 1 clip model, you have these patients getting fluid overloaded, getting flash pulmonary edema, and that is a signal that this may either be a single renal artery which is affected, or the other kidney has been knocked off by some process or been removed, or even actually has gone bust simply because of the effect of renovascular disease. So the 1 kidney 1 clip model starts off as a renin-mediated hypertension and then very quickly becomes a salt-dependent hypertension. The 2 kidney 1 clip model assumes that only 1 kidney is involved and the other kidney is fine. And therefore, this single kidney which is involved with renal artery stenosis is producing the hypertension, and then all the salt that is being secreted is excreted by that opposite kidney which is normal, and therefore these patients continue to be not fluid overloaded, and therefore they are saved. So they continue to have renin-mediated hypertension just because the other kidney is good. But remember, it has to be a good contralateral kidney so that the renin will continue. And this is the main reason for these assays which have been mentioned some years ago in most of the textbooks. So the manifestations, to summarize, of renovascular disease, you can have renal artery stenosis. It can be asymptomatic, as I told you in the first slide of the epidemiology. You could have renovascular hypertension as a consequence of renal artery stenosis, a potentially curable cause of hypertension. As a result of renal artery stenosis, you can get ischemic nephropathy. That means you can get arteriosclerosis, you can get glomerular pathology, and once you get ischemic atherosclerosis of the kidney, then it is very unlikely that in these patients, surgical correction or reversing the stenosis will actually cure the hypertension. And therefore, ischemic nephropathy is a serious consequence of renal artery stenosis in many situations. Renal artery stenosis also accelerates cardiovascular disease and leads to further congestive heart failures, stroke, and secondary aldosteronism simply because of the uncontrolled hypertension. So on the background of coronary artery disease, if you have renal artery stenosis which is significant, then you are in deep trouble simply because of the effects of severe hypertension, which is uncontrollable. Your cardiac profile alters and you can get strokes. And that is why we see some young people at the age of 30 or 40 having a stroke and their first manifestation of renal artery stenosis or renovascular hypertension. The diagnosis of renovascular hypertension is clinical, laboratory, and by imaging. Let's take each one of them. Now, this is an important slide because it is asked sometimes in the exam as to when would you suspect somebody to have renovascular hypertension. Acute onset or accelerated hypertension at any age. That means suddenly a guy is absolutely all right and suddenly bang on gets severe hypertension. Or accelerated hypertension. He's a known hypertensive. He's on medication. He's doing well. And suddenly bang, one fine day, his hypertension goes completely berserk, out of control. If you have severe hypertension in a young child, or a young adult, it's a signal, it's a red flag for RAS. Hypertension which is refractory to 3 or more antihypertensive drugs, there could be some problem with the renal artery. Onset of hypertension in less than 20 or more than 55 years. More than 55 because of atherosclerosis. And suddenly you have a patient with atherosclerosis who's doing well, who's doing reasonably all right. He's got coronary artery disease by atherosclerosis, and then suddenly his hypertension goes out of control. Then you begin to wonder, has he got RAS? If you put a patient on converting enzyme inhibitor and you've induced renal insufficiency, then you've got to think of, so the creatinine goes up with a patient on ACE inhibitors, then you're worried. You're thinking that maybe there is RAS. Flash pulmonary edema. This is a very serious condition. It can occur just out of the blue in patients, and invariably it is a single kidney. And this is the classical Goldblatt one kidney, one clip model, because the other kidney is gone and this is a single kidney which has been affected, which is functioning, and then sodium overload and you get edema. Hypertension with unexplained impairment of renal function. So these are patients, for example, who have got hypertension. They've got renal disease, shall we say renal parenchymal disease, and suddenly the creatinine jumps. And when the creatinine jumps, you begin to wonder whether there has been an occlusion of renal artery. Asymmetric size of the kidney on imaging, a small kidney, the other side larger, again is a signal for renovascular disease. And if you have vascular bruise or signs of atherosclerotic disease in other areas, then you have to suspect that this patient could be having renal artery stenosis, renovascular disease. Let me also tell you that listening to the bruit, listening to a renal artery bruit is a very rare phenomenon. Most of the time, because of the hypertension, you get the aortic systolic bruit, and many people confuse that for the classical renal artery bruit, which is not a systolic bruit. When it comes to laboratory assays, we are all taught that the renin assay is the singular test that is important in trying to diagnose renal artery stenosis, renovascular hypertension. This is a very fastidious test, extremely fastidious, very difficult to assay. There's a lot of, there's a lot of palaver which goes on about this renin assay. And, you've got to make the patient free of all the drugs. You've got to make the patient only on beta blockers. You can't use calcium channel blockers. You can't use ACE inhibitors. You can't use a diuretic. So, you've got to put the patient away from these drugs. And with severe hypertension, it may be extremely difficult for you to exercise this particular process. But nevertheless, you can do a peripheral renin assay. In a steady state, you have to make the patient comfortable, sitting comfortably, recording his blood pressure to make sure we reach a steady state, and take the peripheral, renin assay from that. You can't just take a renin sample and send it off to the lab. There are special tubes available. They have to be put in cold chain, and immediately you get special ice tubes from the lab for renin assays. Many labs don't do this test, and they have to send it overseas. Of course, the other way to do it is to directly target the renal vein, because that's where you have the maximum load of renin being secreted from that index kidney. And this is done by angiographic catheters. The cardiologists or interventional radiologists who are very slick at these processes cannulate the IVC and then get the renal vein and try to assay the renal vein renin assay. Now, what was the reason for this renin assay? The reason why this thing became popular was to know whether the hypertension was curable by any surgical exercise or endovascular treatment. Was it curable? And they came to the figure that if you have the renal vein to IVC renin ratio to be more than 2:1, that means the index kidney is producing 2 times the renin than the IVC or the other side, then that kidney, surgical treatment of that kidney is going to result in cure. So this is an important thing. Some people have said it could be 1.5:1, but when you begin to lower the criteria, then your cure rate automatically starts to fall, and you may get just control of hypertension, as I told you at the start. So renal vein renin assays are done in some labs, in some departments, but by and large, right now, this particular test has not found favor in recent times. Imaging is the hallmark of trying to make a diagnosis of renal artery disease, renovascular disease. And imaging helps you to know whether the problem is unilateral or bilateral. Are we dealing with a solitary functioning kidney? We want to know what is the structure and function of the post-stenotic kidney. That means the kidney's got stenosis, is there a good runoff into that kidney, or is it a withered tree appearance? This withered tree appearance is a classical appearance in somebody who's got renal artery stenosis, and it was derived from patients who had undergone renal transplantation, and as a consequence of renal artery stenosis, you get a withered tree as though it's just a tree with no leaves in it. So this is a very, very classical picture. So if you have a picture of a withered tree appearance post-stenotic renal artery disease, then that kidney is not a very healthy one. We also need to know from imaging, is the stenosis responsible for the hypertension, renal dysfunction, or congestive heart failure? And last but not least, will this condition improve with revascularization, and will patient benefit from renal revascularization? So this is what imaging is going to help us do in today's world. These are all the imaging techniques that have been employed, starting from the familiar minute sequence IVU, the Doppler ultrasound, the renal scintigraphy, digital subtraction angiography, CT angiogram, and gadolinium enhanced MRA. So just to cover, because this is a class, the minute sequence IVU is an age-old test which was done, and the diagnosis of renal artery stenosis is based on the fact that if you take IV, if you inject a bolus of contrast and take films at 1, 2, 3 minutes and then study the kidney, then you can say that, okay, the kidney that is not being perfused, the kidney which is smaller in size, is likely to be the culprit, and it may lead to the diagnosis of renal artery stenosis. To make this minute sequence IVU better interpreter or better diagnostic approval, they went on to do what's called the 30-second sequence IVU. That means every 30 seconds they would take an image to see whether there was excretion on that side when compared to the contralateral normal side. The only problem with this IVU or minute sequence test is that if both kidneys are involved, if both kidneys have got renovascular disease, renovascular hypertension as a cause of it, then this particular test would probably not be a useful one to do. The Doppler ultrasound is a good screening test. It's a good screening test. Again, it requires a lot of skill. It's a laborious test to do if you're trying to look for renovascular disease. On the right side, you have the stomach, you have the duodenum, you have the bowel, all these things causing problems. The left side may be a slightly easier to look at the renal artery because the aorta is sitting close by. But nevertheless, this is a very fastidious test to do, and you require radiologists with extreme skill to actually give you an answer on the Doppler. Renal scintigraphy is used to make a diagnosis again of renovascular hypertension, and we use the famous captable renogram to try to make a diagnosis, because captable, which is an angiotensin converting enzyme inhibitor, will actually reduce the GFR, and that index kidney will show the trace on the vascular spike, that reduced vascular spike. Digital subtraction angiography, when it came in, was an extremely popular way of highlighting the artery. But again, it was an anatomical diagnosis and not a physiological diagnosis. DSA has been replaced today by two very important investigations, CT angiogram, and right now the gadolinium enhanced MR angiography. CT angiogram is what we use for all our kidney donors, and we know that with the triphasic CT, you can get very good images, and many situations you can study the aorta, the reconstructed images. So CT angiography is a very good way of actually knowing the anatomy of the kidney and anatomy of the renal artery. And therefore, many people have actually gone away from doing the conventional angiogram unless you want to do an intervention. If you want to do an intervention, an endovascular intervention, then at that time you do the angiogram and then do the study. But to make a diagnosis of renal artery disease, renovascular disease, CT angiography is an extremely useful test. And today we have gadolinium enhanced MR angiography, which appears to be the gold standard for imaging. Let's take these at a time. Now, this is a DSA, and you can see very clearly the string of beads appears in the top left. Now, one of the things about the string of beads is these aneurysmal dilatations, which gives rise to the string of beads. And it's important to know that the diameter of the aneurysm in a string of beads kidney is more than the diameter of the renal artery. In another condition, which is intimal fibroplasia, you also get aneurysmal dilatations, but these aneurysmal dilatations are much smaller than the diameter of the main renal artery. So this is a good way of actually making that, that distinction. In slide B, you can see that there's renal artery stenosis. This aorta is very irregular, and you can see that there is ostial and proximal renal artery stenosis on both sides. And in the DSA of the aortic arch, as the arrows have indicated, there is narrowing and irregularity of the carotids. So this is a good test to do in many patients where you want to study the entire arterial architecture. Now, this was a standard angiogram done when I was in Velo, and this is a patient who has on the left side, on the right side, sorry, you can't see much of a kidney, you can't see much of a renal artery. This is a very, very selective way, and you can only see the proximal renal artery, and you can't actually see the rest of the aorta. So it's just to show you that this is just a proximal renal artery stenosis in a kidney where it has not yet shown ischemic nephropathy. You can see good runoff distally. The kidney size is reasonable. It's not very small and contracted. And therefore, this is a kidney that could actually be revascularized or endovascularly treated. What is also important to realize is the distal runoff of the aorta. You can see the common iliacs nicely. You see the internal iliacs. So this is just one screenshot to show you a particular variety of renal artery stenosis. Now, this is again showing stenosis on the left side. You can see minimal irregularity of the aorta. There's no aneurysmal dilatation, but focus on the right side. What you see on the right side is, if I run my pointer down, you can see these corkscrew vessels going all the way down. All this is a leash of vessels which are paraureteral. So these are what are called ureteric collaterals. And when you do renovascular surgery, you will come across these vessels which are surrounding the ureter. And this is what gives rise to the classical X-ray appearance on the IVU of ureteral notching. So this is as a result of the stenosis, nature's way of supplying the kidney in a retrograde fashion. So there is a kidney there, and this is collateral circulation. It has been thought, and we were also taught, that collateral circulation indicates that the kidney is of good quality and is well preserved. Here again, bilateral renal artery disease, nice looking aorta, a young patient again with what appears to be fibromuscular disease involving the ostium is fine, but the proximal renal artery is very tightly occluded. Here again, no ostial stenosis, but again proximal. So bilateral intimal fibroplasia. The distinction between intimal fibroplasia and periadventitial is difficult, except for the fact that intimal fibroplasia, as I said earlier, occurs in children. So if you have a child or a young adult and with lesions like this, then you would probably say, yes, it's intimal. It is intimal fibroplasia. This is the same X-ray showing you in a different projection. You can see that the ostium is nice on the right side, and you can see a good post-stenotic dilatation, and you can see good excretion of contrast. This is the ureter. Sorry. This is the ureter excreting the contrast. So this is a good kidney. This is a good kidney post-stenotic dilatation. Now, post-stenotic dilatation again is a favorable sign of surgical correction or possible curability. Possible curability. Mark my words. Now, this is the classical, what we would call aortoarteritis. Now, there are two varieties of aortoarteritis. One is this variety, which is a stenotic variety. And the other is the aneurysmal variety of aortoarteritis. And you can see here, and many people have called this the mid-aortic syndrome, the middle aortic syndrome. You can see that kidneys on both sides. This is a young patient. You can see from the bony architecture and the shape that there is proximal renal artery stenosis, a reasonably good kidney on both sides, extremely irregular aorta, right from the origin, just below the SMA, right down to the bifurcation. But what is interesting in this patient is that in spite of this aorta looking so stenotic and narrow, you see the distal runoff into the iliacs. Absolutely normal. One of those strange phenomena of this disease. And these patients don't have claudication, either gluteal or limb claudication. So it's important when you see something like this to check the blood pressure in the lower limbs, check to see whether these patients have got these symptoms, because it's important. If you want to do any form of renovascular surgery on these patients, then you can't connect it to a disease part of the artery. You can't do an endarterectomy on this aorta. So therefore, this is a patient who many years ago, I did bilateral auto transplant for this girl, and she has done exceedingly well. And this is one of those patients whose blood pressure was controlled very well. She was taking 5 medications for hypertension, and by the time we finished with both sides, she was only on 1 drug. So we wouldn't call her actually cured of hypertension, we'd call her controlled hypertension. Now the Doppler is used, and this is a classical Power Stardust type of anomaly, and is part of the Doppler Doppler study. It's very commonly used in patients who have renal transplants, and you have seen all this patients, people who are involved in renal transplantation. The Doppler is a very, very useful test simply because the kidney is so superficial and one can very easily see the renal artery nicely. Of course, you have to be careful, and again, you need a skilled person because sometimes you may mistake the waveforms from the external iliac artery or even the common iliac in many of these patients. So you need to have a good radiologist who is able to get you a good Doppler signals with the classical findings. Now, this is a CT angiogram of a patient who had the so-called aortoarteritis, and this is the aneurysmal variety of that aortoarteritis. You can see huge aneurysmal dilatation of the aorta, and again, you can see that there is some distal runoff here. Now, I just want you to focus on this artery here. Can you see my pointer? I think you can. This pointer is the IMA, inferior mesenteric artery, and this goes off as the artery of marginal artery of Drummond or the artery of Raiola. I'll show you some better pictures of that. Again, MR angiogram. See how beautifully one can see now in an MR image the exact anatomy in patients who have got FMD and other forms of renovascular disease. This is to show you in a very classical manner the string of beads appearance you can see on this side. So as far as imaging is concerned, today MR angiography is the investigation of choice in most centers, provided of course you have a good GFR. CT angiography is a good alternative for patients who cannot have MRI and is also useful in the follow-up of patients who have renal artery stents. Of course, nowadays, maybe some of the MRs are compatible, but most of us would still go for CT angiogram in patients who have renal artery stents. Ultrasound is mainly used, a Doppler is mainly used, as I said, in the investigation of renal transplant artery stenosis, and not something that we would use for the diagnosis of renovascular disease. Although many people would go for a Doppler ultrasound if they know that their radiologist is very familiar with this. But by and large, if you're suspecting renal artery disease, if you're suspecting renovascular disease in a patient or renal hypertension, then the entire process of evaluation and imaging has changed completely. IBU is out, ultrasound Doppler is out, and you go straight for a 3-dimensional imaging. You go for CT, axial imaging, CT angiography, or MR angiography. And captable renography is used only selectively in young patients, middle-aged patients with normal renal function and unilateral disease. So, captive, again, many of these tests which are mentioned in the books slowly seem to fade away in today's world, simply because you have better imaging to make a diagnosis, which means that are we looking at cure of renovascular hypertension? Are we looking at cure, or are we looking at control? and thereby protecting renal function. I think the thrust today is to protect renal function rather than try to achieve cure of the renal hypertension, which, as I told you, in the very large studies that have been done, it is rarely possible. And the famous study is a coral study, which was done in atherosclerotic disease, where they have actually shown that cure of hypertension as a consequence of correcting renal artery disease is very, very infrequent. So when it comes to medical treatment, this is really the cornerstone. This is really what has changed completely at the face of renovascular disease. The availability of angiotensin converting enzyme inhibitors, and more recently, angiotensin ARBs, and last but not least, renin inhibitors, aliskirenin. So these are fantastic drugs. And right now, the thrust is whether you really need to do any treatment for these kidneys in terms of endovascular procedures, renovascular surgery, as long as their hypertension is controlled, as long as there is no target organ damage, and the kidney is not suffering. There are a group of individuals, many people, who would continue to put these patients on medical treatment. Provided as a consequence of your medical treatment, renal function is not deteriorating. That means single kidney ARB use, you're giving multiple drugs, and the patient is at severe side effects. So while these drugs are very good, you must remember that while there may be a panacea in some patients, it may not be possible to take care of everybody just with medical treatment. So there is a role for some form of intervention in selected individual so that you can at least make their quality of life better. So medical management consists basically of all these medications. Alpha blockers, calcium channel blockers, diuretics. Diuretics are really a mainstay in the treatment simply because I have told you of the volume overload that occurs in these patients due to secondary aldosteronism. Of course, lipid agents, statins, all these are part of the medical management, and we leave this to most of our nephrologist colleagues or our physicians who deal with these patients or who are their primary. The patients go primarily to these patients, to these doctors because of hypertension. What is our role now as people who are involved surgically or with interventional radiology? What is our role? What I see in the future is the role of the knife being diluted. The surgical knife is going to be probably extinct simply because of the revolution that has occurred in endovascular procedures. The availability of some amazing endovascular prosthesis has actually made life very easy for some of our patients because of minimally invasive techniques. And it's only if some catastrophe occurs during the process of stenting or endovascular procedures that the surgeon may be needed. By and large, most patients today have some form of stenting or endovascular procedures, either with a drug-eluting stent or with prostheses which are what we would call covered stents, etc. So when I went to Mayo Clinic, when I go there, I've been there many times to the vascular unit because I have a colleague of mine who's trained in Vellore, who's now the chief of vascular surgery in Mayo. And I spent time with her watching them do these procedures. There's an entire theater suite which is available readily for these endovascular procedures. And many vascular surgeons have learned this technique so that they don't give it away to the urologist, to the radiologist or the cardiac interventionalist. So, this is something that is happening, and it's taking away the steam from many patients who require very major surgical procedures. Nevertheless, surgery has not been left. There is a role for surgery, not to say that surgery is not inappropriate. When it comes to surgical management, we have various types of procedures. We have the aortic approach to renal artery reconstruction. That means go straight to the aorta. You have an endarterectomy, which is selectively used for patients with atherosclerosis. This could be a renal artery endarterectomy or a transaortic endarterectomy. Nowadays, people are doing this with minimally invasive techniques. They use the rotor blade and try to dislodge these thrombi. The only problem with any of these procedures is a shower of emboli or atherosclerotic plaques, which can either go into the renal artery or go distally. So this is a very serious consequence of some of these endarterectomy procedures. If you have a focal lesion, then resection and anastomosis, very, very infrequent, very rare to get these sort of lesions. Or you have an aortorenal bypass. This is a common operation that was done in patients where the aorta is of good quality and the stenosis is very proximal, and you have a good distal renal artery, then you can jump a graft from the aorta to the renal artery. Many urologists probably would not be doing these operations, and only, as I said, those who have been involved with a large series of these patients who come to them because of multi-specialties, referred by cardiologists, referred by physicians, that we have the opportunity of undertaking some of these procedures in conjunction with our vascular surgery colleagues. Splenorenal bypass is an excellent procedure. It's a very neat operation for left renal artery stenosis. And the thing to remember about splenorenal bypass is that you don't need to do a splenectomy. The spleen is actually supplied by the short gastrics, and therefore it survives. So you don't need to do a splenectomy in these patients. So you just detach the splenic artery and do an end-to-end anastomosis to the renal artery, as long as the distal renal artery or the artery distal to the stenosis is normal. You don't require cooling because the anastomosis can be done quite easily in about 10 minutes. Everything is ready. So there is not much of ischemia. And because you have renal artery stenosis, there is collateral circulation to the kidney via the ureteric collaterals. So these kidneys are reasonably perfused. You don't need to actually cross-clamp the renal vein. You don't need to make the kidney completely ischemic. So this is a good operation. But it is an operation that is not to be done in children because the splenic artery supply to the kidney in children is not good. So two things about this operation: don't do it in children, and don't remove the spleen in these patients. Hepatorenal bypass is a good operation. Remember that this is, if you do damage the hepatic artery as a consequence, then you've really gone south as far as the liver is concerned. So you have to be extremely careful when you do this hepatorenal bypass. The other arteries can be used. The iliac artery to the renal bypass graft I have done, this is a good operation when you have a single. We have a single kidney. You have a good aortic. You have a good iliac artery. So the iliac artery to the kidney can be used a nice Gore-Tex bypass graft. Of course, nephrectomy, either open, laparoscopic, or partial nephrectomy. If there is a isolated stenosis of a polar artery, these might help as extra anatomic procedures in patients who have renal artery disease. One of the major thrusts that I personally have been involved with renal artery disease has been in the area of renal autotransplantation, simply because of the fact that a vast majority of our patients had actually Takayasu's or aorta arthritis, and the aorta was so bad that you couldn't use that aorta for anything. And the interesting thing is that the aortic runoff, that is the iliac artery, are invariably good, and you could use an auto transplant. And with our experience of renal transplantation, this operation is like is like second nature to most urologists who are involved with renal transplantation. And you can combine renal auto transplant with or without aortic repair. This means that if there's an aneurysmal variety which has caused stenosis of the renal artery, and that aneurysm is large, as I showed you in one of those X-rays, you could do the aortic repair at the same time as the renal autotransplantation. You could use an endovascular aortic procedure with a renal autotransplant. That means you put an endovascular graft for the aneurysm. You don't do anything to the aneurysm. Take the kidney out and then cool it, and then do an autotransplant, because now the aorta is safe. The risk of dissection and risk of damage to the aorta is less because of the graft that has been put in. Then you can go ahead and do the renal autotransplantation. I've also had the opportunity in Vellore with late Sunil Agarwal to do bilateral simultaneous renal revascularization with aortic repair. This we did on a couple of patients. It's a tricky operation because you have it, but we decided that because of our experience, we could do it on both sides because we could cool the kidney. Once you cool the kidney, then you are safe. You can do the aortic repair at the same time. Once the aortic runoff is done, then you could put the kidney into the iliac fossa on both sides. So you, in one stroke, you have corrected both renal artery stenosis in these patients as well as the aorta. This is the patient who has had aortic graft, and you can see on the top there is a ribbed graft connecting to the renal artery going on to the right side. And what you see here is the aneurysmal sac. You just open the aneurysmal sac and you get one end of the aorta, the proximal end, and the distal end, and sew it with a Gore-Tex graft. And you just close the aneurysmal sac over this graft to prevent any adhesions to the graft. And then at the same time, you've got this renal artery going in there. So, this is a good part of the thing. So we did that first and then did this later in this patient. Now, this is a different patient. You can see all this blood around here. And this is all the aneurysmal sac, which had contained a lot of blood. There was a lot of dissection. And this is a Dacron graft. This is a rib graft that was used in this patient with the renal artery. So again, a combined renal artery surgery along with aortic repair in these patients. Both these patients actually had bilateral disease. In one side, we were able to put a graft to the renal artery, and on the other side, we were able to do a renal auto transplant because it was not favorable for a graft. So, you could actually, if you did have the experience and if you have a good vascular unit and a good vascular team, then these surgeries can be done. Of course, there is a morbidity because these are major operations, but they can be done. Now, today, this entire process of opening the abdomen is completely replaced by endovascular techniques, and therefore, the role for many of these operations is now becoming less and less. So, I think I have spent a fair bit of time in trying to give you an overview. But before I give you the take-home messages, what about addressing renal? At what point do you say that this renal artery is actually bad or this kidney is worth saving? If you look at the angiograms and if you have a 70% stenosis of the renal artery, then people say that that's a significant stenosis. Technically, there should be no gradient between the aorta and the renal artery. Technically, there should be a zero gradient. If there is a gradient of between 10 to 20 millimeters of mercury, then there is a significant stenosis in that renal artery. So 70% occlusion, pressure gradient as measured during the angiography are indications that this patient has got significant stenosis. What about kidney size? A kidney size of 9 centimeters is excellent, but we can go up to 7 centimeters if we have to revascularize these kidneys. Anything less than 7 centimeters could have a problem in trying to make this kidney better. What about the serum creatinine? A serum creatinine value of 4 is the upper limit. And therefore, there are some elderly people with atherosclerosis who I've told you have got a sudden rise of blood pressure. They may have atherosclerotic disease of that renal artery causing a rise of creatinine. These patients may actually benefit with renal revascularization in form of stenting. So these are situations where you have to look at the possibility of correcting these renal arteries. There has also been a school of thought which said that you could biopsy these kidneys on the table and see whether they have actually ischemic glomeruli or they have ATN. ATN per se is not a contraindication to revascularize. But the presence of atherosclerotic emboli in the kidney, in the vessels, atherosclerotic emboli in the vessels is not a good sign. And if you have ischemic nephropathy, ischemic glomerulopathy, then again, this is not a good sign as far as the kidney is concerned to revascularize. And the vast majority of these kidneys actually are much less than 7 centimeters. So if you do have a situation where you're troubled, then you may have to resort to some of these techniques to see whether you want to do a nephrectomy or whether you want to do revascularization. So the take-home message is, primarily today, the role of renovascular surgery is being questioned. The Coral study, the Astral study, go and read it up, will tell you what is the exact role of renovascular surgery today. There has been a singular lack of controlled studies, and this has led to why renal artery stenosis surgery is just, shall we say, a one-sided story. It's not something. But at the same time, we know that drugs have revolutionized treatments, but as a consequence of severe hypertension, not being controlled by drugs, more than 3, patients having significant side effects, you need to do something for them. You can't leave them alone on drugs just because you don't have a study which says that surgery or endovascular procedures cannot be helped. So instead of surgery, endovascular treatments have actually surpassed many invasive procedures today. Interventional radiologists have become extremely slick. Many vascular surgeons have also become extremely slick at these endovascular treatments and has replaced many of these aortic surgeries which are being done today. All we need to remember at the moment is surgery rarely cures in the vast majority of patients, and all we can do is to make hypertension controllable. Finally, one last word, I haven't mentioned it in the take-home messages, is about renal transplant in patients who do have some form of aortic disease, who do have some form of aortoarthritis. Where are we going to put these kidneys, these transplant kidneys? If the aorta is good, invariably the thoracic aorta in a vast majority of these patients is good. So you can run a graft from the thoracic aorta to this kidney, the transplant kidney, and you can do an orthotropic transplantation, or you could do deal with the aorta by an endovascular procedure, get the distal runoff going earlier, and then put this kidney into the iliac fossa, because invariably the iliacs are pretty good in these patients. So there are ways by which renal transplantation can be done in these patients. It's not that something that you can say it's not possible. It is possible. But at the same time, many of these patients who have landed up with this trouble are very old, and they have significant comorbidities, making transplantation in them a very hazardous exercise. So this is what I have to tell you about renovascular hypertension. This is a topic which many people would probably not be involved with, not interested in. But as urologists, as people who are dealing with renal transplantation, we will be faced with patients who do have renovascular disease. As long as we understand the pathology, the pathophysiology, the progressive nature of some of these diseases, we can then offer appropriate therapy for our patients. So thank you very much, and I will be happy to take any questions from you.
Thank you, sir. Thank you for the lecture. As you said that most of the general urologists won't encounter these questions, these cases, and therefore there are hardly any questions in the chat box, but it was really nice to hear you, and the views which you have expressed and the clarity of thoughts which you have was really very good. I request any members to please post their questions in the chat box if there are any. And while questions may be posted, sir, I would like to ask you that given a choice, if a patient has ostial renal artery stenosis and he is a young person, and would you like to first go ahead for the recent percutaneous techniques, or would you like to offer him a definitive management by surgery?
That's a very, very, very good question. And I think today the thrust is on not angioplasty, but stenting. And using a drug-eluting stent appears to have a good success rate. In terms of long-term, I mean, you're saying a young person. That means if you say somebody who's 20 years old or 25 years old, we don't know whether these stents will last that bit of time. And therefore, in many of these patients who are young, I personally have offered surgical treatment. Simply because I do not know whether I've seen patients with blocked stents. I've seen patients who've had endovascular procedures, stents being put in on both sides, and both sides stents have been blocked. So in young people, my preference would be to do surgery. Probably because I'm a surgeon, but it's just that in the young person, we don't have enough data to stretch to 25, 30 years on stents.
Yes, so this was the main reason why I put this and said that he's a young patient. Because, sir, if you would agree that most of these patients first go to physician.
You are muted now. Right.
Yes, sir. Definitely, these patients first go to a physician, and therefore, it is their decision, and they always feel that doing something which is minimally invasive has better outcome. And I don't know whether you have experienced this, that most of the times we get patients who have blocked stents, or the stents have been improperly placed, and then they are in more difficulty rather with their original disease.
Now, because of a lack of time, I didn't show you many angiograms where stents have been put, they are displaced, they are perforated, bilateral stents, bilateral occlusion. So these are problems. These are problems, and while it's very nice that you have done a minimally invasive procedure for a young person, the long-term outcomes are something that we still don't know. And therefore, as I said, my personal preference would be to offer surgical treatment.
Yeah. So we have two questions, one from Dr. Lakshman Prabhu and one from Dr. Santosh Kumar, who have raised their hands. I request you to please unmute yourself and ask your question, and then we'll take the other two questions in the chat box.
Yeah. Can I come in, ma'am?
Yes, sir.
Thank you very much, sir, for a beautiful talk. And you would recall that there was a time when not recording blood pressure in a renal case in the examination was considered as a palpable error. And we were taught that you can put the stethoscope, in the front, back for a bruit and a machinery murmur. How often you can elicit this sign? I've seen this in penetrating injuries, but this is just out of, just to bring back those old days of classical teaching. Thank you very much.
As I mentioned during the process of this, during my lecture, that the classical renal artery bruit is very rarely heard. Most of the time, because of severe hypertension, what you're hearing is the aortic bruit. And if you press on the aorta very hard, you will hear a bruit. That's not the classical renal artery bruit, which is actually a diastolic bruit. So you don't, you're mistaking that. So, yeah, I have heard the renal artery bruit in only 2 patients that I can remember. In all the renal artery stenosis that I've seen, the classical renal artery bruit, I've heard it in only 2 patients.
Thank you, sir.
Yeah. Yeah, Dr. Santosh.
One more thing, Lakshman, one more thing about blood pressure. One of the things I found is that people don't check blood pressure in children. They think children don't have blood pressures, or they're not hypertensive. You don't. If you ask for a blood pressure instrument, they'll give you the adult cuff. They don't know what is blood pressure in a child, and therefore it is very important that we do. If a child has renal failure, you do not know what the cause is. There's something strange going on. Just make sure that you're not missing out renovascular disease in such a child.
Yeah, true, very true, sir.
Yeah. Dr. Santosh, please go ahead, and I take the questions in the chat next. Can the please unmute Dr. Santosh? Yeah, in the meanwhile, Dr. Chawla sir, you can ask your questions. I'll tell the team to unmute Santosh.
Yeah, I've got unmuted, sir. Thank you so much. It was a pleasure listening to you after a long time. And I have the fortunate this thing to follow up your patients whom you have operated. And they are all being followed up by me. And it's a pleasure to see a lot of these young people from the Northeast whom you have done these revascularizations, who are normotensive without drugs also, and some with very minimal doses, 20, 22 years Means they were children and now they are adults, and they're still doing very well with absolutely normal renal functions. I think the other thing which we have to do is these unnecessary stentings that are being done. I think there is definitely a role of a multidisciplinary team, because the cardiologists are only looking at pipes from inside and unnecessarily putting stents, drug-eluting stents into everybody. So I think the nephrologists, cardiologists, and the urologists should be involved in management of these patients, which unfortunately doesn't happen because we are only told in the end to come as a standby in case something happens. That is the reason why urologists get involved.
Thank you,
Other thing
Santosh.
is, sir,
Thank
sadly,
you.
that is
Thank you, Santosh. It's very, very nice and to hear that some of the patients we have done surgery on are doing very well. It is certainly has lifted my morale after reading some of these studies and papers which have come. And yes, I entirely agree with you about, you see a stenosis on the angiogram, you want to do something about it. This is what the interventional guys are doing all the time. There's no role at all for these sort of procedures. And I don't know if you remember that we actually lost a kidney. We actually lost a patient also because it was too late. The cardiologist had ruptured the renal artery in a patient who had an incidental renal artery stenosis. Nothing wrong with her at all. This happened to be a staff relative, and she actually died on the table because she bled. It was too late. It was too difficult to get her into the theater and do the procedures. But this is something that we need to focus on and need to tell our colleagues. And I agree with you that just like malignancy, we should have a multidisciplinary team approach to patients who have got renovascular disease.
and also the immunomodulatory drugs, which
Yes,
are
yes.
also a lot of time forgotten in the management of these patients. Other thing sad is that, sir, we are hardly having referrals for renovascular hypertension now. There are very few things that surgery can fix and cure. And if you have a young patient with very recent onset, severe intramural hyperplasia and other things, they could be literally cured of their hypertension for life with surgery. And unfortunately, now that is not happening. They will only have endovascular as of today. The referrals we are having and the numbers we are treating now is much less. And cardiology is going gaga with doing very difficult procedures now, endovascular.
Yeah. That's what's happening across the world.
Yeah, thank you, Santosh. I'll invite Dr. Chawla to ask his questions. And in the meanwhile, I'll also take one question from Dr. Bhagat, and he is asking what is the lower limit of GFR to do an auto transplant, and others may ask their questions. Yes, sir, Chawla.
Okay, I'll ask. Okay, sir, I agree with what Dr. Santosh was telling and what you have put in your presentation also. It's exactly the same scenario. I think when we were working in as a resident, probably we used to see a few cases in a year with renovascular hypertension, but this is absolutely for the last 1 decade. I have not seen any patient where it is referred to us directly. These are the patients which from physician get to cardiology, and cardiology, whether they do MR or CT, and to interventional radiologists and some, they will have their own intervention. But there have been few cases where because of the loss of function, because the stent didn't work or the stent got blocked. I just want to ask, if somebody has got a stent and you are planning a laparoscopy, can you just go distal to the stent and take out the kidney, or you need to get the stent along with the kidney? That is the question number one. And question number two, supposing you have a patient who has cerebral artery stenosis with hypertension.
I can't hear the questions, Arun. There's something wrong with your mic. I don't know whether. Okay. Let me take the first question. Is it when you're doing an nephrectomy in a patient who's got a stent?
Regarding few cases which we got for nephrectomy, and if you're doing a laparoscopy and the patient has already a stent put, can you do the nephrectomy with the stump distal to the stent, or you need to put the stent along with the nephrectomy?
Let me tell you, taking out the stent is not an easy job at all. It is virtually extremely difficult to pull everything out. And if the stent is blocked totally, then you can take the kidney out beyond the stent as long. But invariably, you will find that there is some flow inside these Taking it out is a hell of an exercise. I have done it, taking out the stents which are blocked, but yeah, it just gets embedded inside. It's like a mesh, you know, it's like these meshes which are put for, you know, TVT meshes and all the rest of it, you know, it's like that only.
Yeah, a lot of reaction and all that. Very
Yes,
difficult
yes,
to trace where you are. Yeah. And second question is, if you have a post-transfer scenario, you have a renal artery stenosis based on the hypertension, which as well, of course, with the preserved renal function. And how early you can go for endovascular management of renal artery stenosis in a post-transfer?
Very good question. We were faced with this in Vellore. I don't know whether Santosh would remember. It was a patient who had a transplant, and very soon after surgery, his blood he got pulmonary edema, and they did a study and found that there was renal artery stenosis, and we checked up and found that yes, the Turkish guys seem to have had the experience of doing an angioplasty with stenting on hepatic revascularization stenosis, because that's very critical. If the hepatic artery gets going, it gets lost and finished, the whole liver goes. They did it. So we said, let's try this, but we kept the theater on standby. The moment the cardiologist put the balloon and stretched the artery in that particular index case, the first stretch was okay. But when he inflated the balloon a little bit more, there was a wisp of contrast. I said, take the patient to theater. So I think it is very dicey if you're doing it within 2 days, 3 days and all. And I would say if you're going to do something, wait for a minimum of 6 weeks before you actually do some form of stenting. It's very tricky. I wouldn't risk it. I wouldn't risk it. My experience has been one case, and I'm not going to take that chance.
Yeah. So one final question. In your opinion, if you have a strong suspicion, especially the young patient, can we skip this imaging like MR, DSA and all that and straightway go for formal angiogram and a procedure intervention right there and then only?
Yeah, this is what I mentioned, that, you know, today we are not looking at curability of hypertension. Although renal artery stenosis is supposed to be a curable form of hypertension, we are quite willing to accept that we are not going to get a cure, but we can get significant control of hypertension and make the patient's quality of life better. And therefore, if you have a stenosis which is 70%, patient is hypertensive, has got drugs, why do you need all these tests? Why do you need renin? Why do you need captable renography? Things have changed completely, you know. So the entire thrust is changed now from many of these studies. Nobody's doing renin assays at all now. It's there in the books, but hardly anybody does it. Nobody's doing captable renography, because every patient is on ACE inhibitor or is on ARBs. So it's a very different scenario that is happening today in the world. So we just go ahead, do the CT angiogram, see the stenosis. Many people don't even record the pressure gradient. And this is where I think, as Santosh said, the issue, that somebody just does a coronary angiogram, finds a stenosis and goes and treats that also. That is wrong. If you have got that sort of situation, if the patient is hypertensive, prove that he's got renovascular disease, renovascular hypertension, many drugs are being used, and then treat that rather than just blindly stent anything that comes your way.
So there is a question in the chat box, is what is the GFR at which you would do?
As I said, a creatinine which is more than 2, but less than 4. Between maximum is creatinine 4, where you can have a situation where you can say that, I may probably be able to salvage. But again, at that creatinine, I would, if I'm doing surgery, I would like to do a biopsy of that kidney. I should be able to do a biopsy to see whether I've got atherosclerotic emboli on that frozen section, or have I got ischemic glomeruli. So if I've got those conditions, then they are bad. So, you know, you probably do a nephrectomy or whatever there is. So you've got to be sure that it is actually necessary. And this is where your endovascular treatments might help it, because you're not doing open surgery. These are very, very few patients, not everybody. They're usually elderly patients. They're usually patients who've got atherosclerotic disease. They've got coronary artery disease. And therefore, you want to do something like this. So if the creatinine, if you've been monitoring them, the creatinine was all normal and suddenly it goes up, then you have to do something. Then you have to do something. Sudden worsening of hypertension in a patient means that that stenosis is significant, means that it requires treatment.
Okay, sir. Sir, one more question asked by Dr. Suresh. I'm not sure. Is indication of nephrectomy in a patient with renal artery stenosis?
Well, small size kidney, 6 centimeters, anything less than 7 centimeters, because it won't be functioning.
Yeah. Okay, sir. And would you do this biopsy pre-operatively, which you are mentioning, or would you do it as
because
a
it would
frozen
not,
section?
many people would not be doing these biopsies previously because the patient is so hypertensive and these kidneys can bleed. So you do it on the table. That's why I said
As a frozen section.
frozen section. And you must discuss it with your people who do have expertise in interpreting the kidney on a frozen section. So you must have people who are uropathologists, who deal with renal disease, not uro-oncologists, oncopathologists. They don't deal with renal artery disease. So there are specific people who deal with looking at kidneys, parenchymal disease, and they will be able to help you with this. So it's usually in large institutions, so not in small places and all that. So
Yeah. And one more question is, should we involve a vascular surgeon?
No, I don't see anything wrong especially if you've got a large aortic disease and everything else. There's no harm. I mean, I really enjoyed working with late Sunil in Vellore with these cases. Santosh will bear me out. He was also involved in a large majority of his patients. So it was a good team effort. It was a good team effort which gave a lot of these patients solace. They were able to get good improvement from their hypertension and also the aortic disease. So you have a team and it's possible.
So, sir, I thank you for the presentation, and
thank you.
as there are no more questions, sir, I would request Dr. Arun Chawla, sir, to give the vote of thanks, and we can.
Yeah.
Just I said, yeah, no questions, sir.
Thank you, sir. Thank you for accepting our invite and giving a very, very excellent presentation. A comprehensive, I think initially what we were expecting that it will cover the subject. You have encompassed all the relevant points, what is important for the resident, right from the etiology to the evaluation to the endovascular management, and showing a good clips of the images along with the some surgical steps also and the surgical pictures also. I think residents would have got great benefit. Personally speaking, I benefited a lot from this presentation, and you made some few points clear about the few scenarios which I faced during last 1 or 2 years in managing these patients. Thank you very much. And
thank you to ISU, thank you to USI for this opportunity.
Can you sign up?
Yes, sir. We can sign up.
Thank you.
Thank you. Good night, everyone.
Thank you.
Thanks.